And I'll start to introduce Kushang Patel. He's actually not a old friend. We recently, other people in our group have known you for a while, but I only came to know you when you got involved in the backpack and the best studies, and then we had you out to give a talk, and that was a delightful talk, and so now you got on the program. So welcome.
Thanks so much, Dan, and I just want to just say that I'm humbled to be here. It's a hard act to follow Andrea as well as Roger, and what an amazing panel that we had earlier today, and then the accomplished investigators from this morning. I misunderstood what what today was going to be all about. I thought it was going to be smaller and focused on trainees, and so I've been busy redoing my slides. But I'll start by just saying that, disclosing that I come from Seattle, and so a city of approximately 4 million, and so I don't necessarily have lived experience of being in a rural area, but I've been doing a lot of work in this area. So what I plan to do is do a brief review of the demography, really talk about some of the challenges of defining rurality or rural areas, and then describe some of the epidemiology of pain and according to urbanicity or rurality. And then I want to just share some of the work that I've been doing on trying to expand evidence-based pain treatments across a variety of studies at different levels of investigation or stages of investigation. So I think this is a common refrain that rural areas are older, sicker, and poorer. And while that's on average true, I think there's a lot of diversity in the rural landscape. And here I'm just highlighting some known differences between rural and urban areas. In the latest Census 2020, approximately 20% of people in rural areas were 65 and older, in contrast to urban areas at 16%. There's a lower income among people who live in rural areas compared to urban ones. And then I think everyone here will appreciate that access to care is more challenging in rural areas, as illustrated by this statistic here showing that that on average there are 13 physicians per 10,000 people versus 31 in urban areas. Now, I would just want to really emphasize that when you look at papers, demographic or epidemiologic studies, looking at rurality to really try to attend to the definitions that are being used or the way they're defining their exposure. Here you could see Census 2020, the U.S., the latest decennial census for the U.S., estimated approximately 60 million people live in rural areas, or approximately 20% of the population live in a rural area. In contrast, USDA's definition is that 46 million people live in rural areas and comprising approximately 14% of the population. And so the government has, at least from what I've noticed in papers, at least 6 different definitions of rurality or rural areas. And I just wanted to highlight one of the most common used definitions that comes out of the Census Bureau. So this is just a graphic depiction of how they go about defining rural. And it's really, they start by focusing on geographic boundaries and then take into account the population density of areas, the land coverage, and then access to airports. And then they further consider, more recently, they've been considering distance to metropolitan areas. And then all of that gets fed to identify urban areas, and what's left over is considered rural. So there's not really truly a rural definition of what's rural. It's really what's considered urban. And so this leaves a lot to be desired. There's often going to be, or this process works well for really identifying, small towns that are more isolated, that are occupy a large land area, and then very clearly identifying large urban areas. But there's so many situations where you have areas that are more blended, and it's hard to make a determination of what's really rural. So I'm not going to dwell on this more, but just bringing that to your attention that there are many definitions of rural areas. I did want to say, though, that that rural areas in the United States are becoming more diverse in terms of race ethnicity. These are data from 2018, but a new analysis has been published of Census 2020 as well, showing greater diversity of rural areas. And the reason why I show this map is I think it's really nice in that it really highlights the legacy of historic racism. You can see, sorry, I should point out that these different colored areas represent rural areas with populations of greater than 20% racial ethnic minorities. So, and then the gray represent urban areas. And you can see pretty quickly that the orange dots, or orange areas rather, represent counties or areas with large black populations, and the purple areas represent Hispanic, and then I'm terrible with colors, but you could see American Indian and Alaska Natives are interspersed. And so you could see that, the historic legacy of slavery, as well as colonialism, as well as the access to the needs of these populations will differ quite dramatically. So just wanting to emphasize that the needs for a rural area is going to depend heavily on what part of the country they are on, as well as the racial ethnic composition of the area. So I just want to highlight some of the health status by rurality. And unlike Roger and Andrea, who have really nicely summarized a lot of population-based data or some neat survey work, there's a lot less available around pain. But I do think it's important to note that there's clear differences in mortality, where you can see here that generally there was a, between 1999 and 2009, very parallel rates of decline in mortality, but then it stalls in rural areas for the more recent past decade, whereas there's a slight decrease, continuing decline in urban areas. And so what that does is you have a 7% difference in age-adjusted mortality rates here, and it's grown threefold by 2019. And for all the leading causes of death, you see that rural areas, the mortality rates are higher in rural areas compared to non-rural areas. I guess I'll just, for the sake of time, there's, I think many of you are likely familiar with the high prevalence or the high mortality rates due to drug overdoses happening in rural areas compared to urban ones. But it's, but those differences have been narrowing over time. So these stark differences in mortality likely reflect the characteristics, the health characteristics of people who live in rural areas. And you can see here that the prevalence of tobacco use, obesity, physical inactivity are higher in rural than in urban areas. And then the rate of multimorbidity is also higher in rural areas compared to non-rural. And even when you account for age, you still see these differences. So there's a greater burden of disease overall in rural areas, and certainly obesity and physical inactivity can contribute to a lot of musculoskeletal pain. And so, in fact, when you look at the prevalence of chronic pain and high impact pain, you see a very graded relationship according to greater, as you increase in rurality, higher prevalence of chronic pain, as well as high impact pain in rural areas. These, there is a more recent estimate from NCHS from 2019 to 2021 showing very similar higher burden of chronic pain and high impact pain in rural areas. This was a nice graphic, so I stuck with this. Also, there's been some nice work on arthritis. So here you could see these are just different levels of urbanicity, and the orange and red represents more rural areas, and you can clearly see higher prevalence of arthritis. And then among those with arthritis, there's a higher prevalence of arthritis attributable activity limitations, so functional limitations associated with arthritis. And then among those with arthritis, the prevalence of physical inactivity is higher. So I borrowed this slide from Julie Fritz. She gave a talk at the NIH collaboratory meeting a few months ago, and I guess there's a little mess up here, but what I wasn't aware of is last year the Kaiser Family Foundation published a survey, a national survey, asking adults a wide range of questions regarding addiction. And here you see that 4 in 10 people in rural areas have a family member or they themselves have been addicted to opioids, and that's double the rate than in urban areas. I spent a lot of time trying to find data on the prevalence of different non-pharmacologic treatments according to urbanicity or rurality, and there's very limited data. There was a really nice paper published in JAMA Network in 2022 using the NHIS and showing documenting improvements in the rates of non-pharmacologic treatment for chronic pain in general population across different demographic groups, but they did not look at levels of urbanicity. But here you could see in a telephone survey of adults in North Carolina in 2018 that non-pharmacologic treatments are less likely to be sought or received by people who have chronic pain in rural areas compared to urban areas, and they're slightly more likely to receive prescription opioids, and that's shown more clearly here. This was a nice analysis of EHR data from a large vendor of health records. And so this set of investigators looked at Among opioid-naive patients who present for the first time for chronic back pain or for back pain and knee OA and I believe neck pain, they wanted to examine pain treatment according to urban-rural, as well as type of provider, and you can see very clearly that regardless of provider, providers in rural areas were more likely to prescribe opioids versus those in urban areas. This is accounting for a variety of potential confounders. There are limitations to this work, but I think it's reflective of that earlier study. And here, this is referrals to physical therapy, and you can see a higher rates of referral among urban providers versus rural providers, which is likely reflecting lack of access to physical therapists in rural areas. And sorry, these data are from 2017. So the lack of access to physical therapy is of great concern because numerous clinical practice guidelines recommend exercise as a first-line treatment for common chronic musculoskeletal pain conditions, and there are numerous benefits for physical activity that has been summarized by a fact sheet published by ISP last year. I've been very interested in rural health for a while because my in-laws live in northwest Montana, and I've seen the challenges that they've faced, and so I did some qualitative work, and we interviewed primary care patients who have knee OA in a rural area of Washington state. And these patients identified a number of barriers to accessing exercise or physical activity, and that includes a lack of exercise facilities or consistent options that they can access, difficulty with transportation. If they had their own mode of transportation, often the trip itself was so far away and painful for the person that it was a disincentive for engaging in physical activity. Also, the infrastructure of rural areas is quite limited for walking, and there's long distances between destinations such as grocery stores, cafes, and so again, limited opportunity for recreational walking activity. And then in tribal areas, there's been some nice qualitative work done showing that women are particularly concerned about abductions, which is a major concern among Indigenous women, as well as wildlife, and inclement weather is a challenge in many rural areas. So with these barriers in mind, we, like many of you, pivoted to remote delivery of a variety of different pain treatments. A few months into a clinical trial evaluating the combination of cognitive behavioral therapy and exercise, we had to shut down because of COVID, and so we took a deliberative approach to adapting our interventions for remote delivery, and I'll describe those briefly, but I just wanted to highlight the exercise program that we were using is called Enhanced Fitness. This is a evidence-based exercise program that is widely disseminated in the United States by an organization called Sound Generations. It's available in over 800 sites nationally. It meets typically 3 days a week for an hour, and it involves multi-component exercise, balance, strength, and endurance training, all things you would want a person with chronic pain to engage in. And because this program has been shown through randomized controlled trials to improve physical capacity and pain and health-related quality of life, the CDC recommends it for arthritis management. And so we adapted it for remote delivery by, like I said, taking a really deliberate approach of engaging key stakeholders, including older adults who previously participated in enhanced fitness instructors, as well as the leadership, asking them what would they like out of a tele-exercise program, what concerns they have about safety, about technology, and about effectiveness. And so with all that feedback, we adapted the protocol, pre-piloted it, and then finally piloted it in a sample of 44 older adults with painful knee osteoarthritis. We've had that initial pilot was very successful. We had a median attendance rate over a 3-month period of 90%. We didn't look at outcomes because this was a part of our RL1 clinical trial. So, but based on this and another pilot study, the organization Sound Generations had disseminated this protocol to all 800 of their sites. And so, so we did, once we had this protocol in place, I really wanted to see if this would be feasible to deliver in rural settings. So in order to access older adults with musculoskeletal pain, I'm sorry, I'm running 3 or 4 minutes, okay. So we partnered with Arbor Health, which is a rural serving healthcare system in Eastern Washington, and we did a pilot study. What we found was that, again, in rural older adults with knee OA, we had a high rate of completion. 87% completed the 3-month exercise program. The median attendance was 91%. We saw clinically meaningful improvements in knee pain, function, and physical performance-based assessments of such as time up and go. There were no serious adverse events, and participants were very satisfied. I think I'd just like to share that that this is a live stream program, and so people do it from their home, and that was a huge. The convenience factor was huge for many patients, some of whom were caregivers and did not have time to go to a center or to participate in exercise. Also, the group-based intervention was key to helping motivate people to stick with the program and complete it and attend most sessions. And then there's a lot of camaraderie that develops through this class. We open up the classroom for participants to visit with one another, and then at the end of the class, we leave it open for the instructor to field questions from participants. Often these are deconditioned older adults, and so they're uncertain if they're doing the exercises correctly, and so this support was huge for these patients. And I guess we'll just skip to, just wanted to highlight that through working with Arbor Health, we really, we were able to access this population of older adults with chronic musculoskeletal pain, and they really helped with promoting the project and engaging patients, and that was really key for many patients. But even still, we found that patients were asking their providers about whether or not this program would be good for them, And so with that in mind, we've then got, for those trainees out there, a lot of this is just really small pilot funds, like $10,000, $20,000. And so we tried to develop a primary care pathway for referral to remote delivery of an enhanced fitness with a federally qualified health center in Casper, Wyoming. And the study was, I'm just going to forward it here, called COPE. And we learned a lot of lessons about trying to implement a exercise prescription pathway and referral for older adults with musculoskeletal pain. And although providers were really supportive, they did not have, there just wasn't bandwidth to counsel patients. And so based on the lessons we learned from this pilot study, we recently got funded to do a hybrid type 2 implementation and effectiveness trial where we are using nurse care managers to deliver cognitive behavioral therapy remotely, do care coordination, as well as counsel patients with chronic pain, rural patients with chronic pain, on exercise and physical activity. And if the patient is ready and willing, they make a referral to remote delivery. And so we are just in the UG3 phase of our project and are piloting this model in 2 rural serving healthcare systems, one in Eastern Washington and one in North Carolina. So I will stop there. Sorry.